All right, guys, we are going to get started with the next speaker. And it is my pleasure to introduce Dr. Mark Blumenstein. He is a 1990 graduate of the University of California of Los Angeles with a degree in biology. He received his optometric degree from the New England College of Optometry in 1994. And after graduation, Dr. Blumenstein finished a residency in secondary ophthalmic care at Barnett Delaney Eye Center in Phoenix, Arizona. He received his fellowship from the American Academy of Optometry in December 1998 and is a founding member of the Optometric Council on Refractive Technology. Currently, Dr. Blumenstein is at the Schwartz Laser Eye Center in Phoenix, Arizona. And I've actually known Mark for a really long time. He probably doesn't remember this, but when I was a resident in St. Louis, Missouri, you flew out there and gave a talk to the Optometric Society there. So,
oh, yeah, I did.
Yeah, so Dr. Blumenstein is, he's very famous in the lecturing world and a dear friend. So please welcome Dr. Mark Blumenstein.
Thanks, Stephanie. Thanks. Thank you, everybody, and all you guys sitting at home with in the bathtub or wherever you guys are doing virtual. I'm unlike Melissa. Melissa's like said she was super excited to go live. I'm not. I mean, I would sit in this little purple room, my daughter's old bedroom, and just like sometimes I'd pretend the internet went out just so I could pretend I'm doing something else. And yeah, it was good times. So I think there's a little bit of what we're going to talk about today is a little overlap. And so if I do say something that Melissa's already said, then just remember what she said because she says it much more profound than I do. I do want to carry on the rap theme though a little bit. Oh yeah, that's me. Look at that. Woo. That's what I look like. Somebody told me the other day I look like David Cross. And I'll be honest with you, it's hurtful. And I looked at that person and I said, you're dead to me. And then my wife said, seriously? I'm like, she goes, Mark, with the whole thing, and if you don't know who David Cross is, look it up, and then you'll go, oh yeah, and then you'll show the phone to everybody. The people at home are already Googling it, and like, oh yeah, Arrested Development, I love that guy. With that being said, keeping that rap thing going, there's two things I want to say. First and foremost is that I take dry eye a little bit differently. I don't think of dry eye as the disease that you should specialize in. I don't think that dry eye is something that you need to quantify or qualify. I think that it's just something that inherently we have to be doing every single time a patient walks into the chair. And to me, the bigger thing is that the word dry is just so bizarre because it's almost like the antithesis of what you would think. I mean, when you say to a patient, is your eye dry? You're basically asking them to define something that you don't know what their definition is. And I say this all the time because I mean it to be true, is that I always think of it as like the word love. Love is so undefinable. It means something so different to other people. I mean, I know I love my wife who tells me that I look like David Cross because literally we'll be spooning it in the middle of the night and the woman has the hottest breath in the entire world. And when she's blowing it on my back and I feel like mushrooms are growing and steam and I know I love her because I don't just shiver with an elbow. I wake up in the morning and she says, how'd you sleep? And I say, amazing. Yeah, great. Yeah. Sadly, she heard me tell this story once and she goes, fine, I won't get close to you. And she thought that was punishment, but I'm like, thank you. I'm carrying on this theme of rap music that LP dropped on the Demodex that Melissa brought to you. And if Melissa could, she probably would have showed you about 2 hours worth of Laura Perriman videos and just stories. But I always kind of liken myself to the rapper who just passed away, RIP, rest in power, Shock G. Now, if anybody here doesn't know who Shock G is, that's shameful. That's really shameful. But Shock G was the lead singer of the Digital Underground. Shock G is actually the person who actually brought Tupac Shakur to our awareness. He wrote a couple songs for him, but I think Shock G is probably more famous for the Humpty Dance because he's Humpty Hump. Humpty Hump, right? For those of you at home, you missed it. I was just like grooving. I will have to say too, this microphone makes me feel like I'm part of like, like a bad boy, like a boy band. Bye-bye, right? I don't know. Anyway, so Shock G, the Humpty Dance The very opening line of that song is literally how I feel our profession and me personally treats this disease that we call dry eye. And literally, if you listen to the song, it basically says, stop what you're doing because I'm about to ruin the image and the style that you're used to. And to me, we have to do this with this disease state we call dry eye. Melissa made such great points about the fact, especially with MADE, right? Look, she made, see how I did that with that acronym, mask associated dry eye, is that we have put such an emphasis on our eyes. I mean, I look at patients now and go, damn girl, those lashes are on point. And she's like, yeah, they cost enough. And I'm like, okay, right? I mean, or literally when you look at a patient and they do have a mask on or they're doing other things, your first thing as an eye care professional is we go straight to their eyes. So to me, why would we, when we walk into a lane, not say to ourselves, what can we do to help these patients? These are my disclosures, full disclosure. These are my disclosures. So to me, yeah, I have no association with anything, any stock except Starbucks. So let me just get that Starbucks. So to me, I would tell you is that you should walk into a lane and instead of saying, prove to me that you have this disease state, your mindset should be prove that you don't. And if you go into this with this notion, I mean, it's almost kind of like, again, I keep talking about relationships, right? You're dating some bad boy or some bad girl, and you go into this knowing darn well that they are, but you are going to basically prove to everybody else around you that you can change them. No, you can't, okay? They are who they are. They're telling you who they are. Believe them. And especially when your girlfriends come up to you and say, oh, honey, no. To me, when you walk into a lane, everything that Melissa said that your patients are doing, they are doing, right? The Mandalorian is not going to get watched by itself in 2 nights, okay? Seriously, Baby Yoda with that baby egg and right? I mean, seriously, the Mayor of Easttown, that was legit. 3 nights, I watched all 8 episodes. So I'm on Bosch season 7. Anybody watching Bosch? Oh, so legit. I'm almost done. I'm on episode 9. It came out on Friday. My point being, all the people that are online virtual right now, they're doing exactly what we're doing. And everything that Melissa said that led up to this means that when they come into our chair and they say things like, I just thought it was time, or I'm just here to update my glasses. What I say is, no, you're not. Okay. You're here for me to tell you what you need to do to be able to do the things you want to do, which is screen time, which is, sit in an air conditioned car and have it blow in your face, especially here in Nevada or in Arizona. You want to be able to accomplish the things you want to. And so to me, one of the things that we have to stop doing is asking our patients to define this disease for themselves, is we need to give them the disease. Patients don't come in and we don't ask them, do you have diabetes? And they're like, well, my urine is a little sweet tasting, so maybe I'm pre-diabetic. No, they come in and they basically say, what's going on? We give them this disease. Think about glaucoma. Do you ever ask a patient, do you have glaucoma? No, you say something like, have you been diagnosed with any eye conditions? We give our patients glaucoma. We give them that by basically, in a small sense, proving that they don't have it. We look at their nerve, we look at their pressure, we talked about their family history. And so to me, we have to do this with this disease state. Now, to me, one of the things, especially when we talk about dry eye, and I'm going to try to avoid ever saying dry eye. I do. I literally will go into a lane and I'll say something like, you have dysfunctional tears. Or I'll say, you know what, the quality of your tears. Or sometimes I'll just look at them and say, you Miss Jackson. And, excuse me? I go, your eyes are nasty. You're nasty. Okay. Now, granted, it's probably some like 48-year-old dude who's going, okay, whatever. And then I knew he watched Schitt's Creek because he's like, well, okay, right? And you guys know who watched Schitt's Creek, what I'm talking about, because that's their journey. To me, there are signs all along this pathway when we go into a lane of our patient telling us that they're having problems, but they don't know that they're having problems. First and foremost, if your patient asks you what you think about blue blocking lenses for the computer, I think you already know that they're telling you, I'm on the computer just a tad bit too much. And more importantly, I think I'm having a problem. And so I will literally tell patients, you know what, they're contraception glasses. If you never want to hook up with anybody ever again, put those lenses on. You think rolling in your cubicle and going, hey girl, what up? She's going to be like, not with those glasses on. And no. To me, that's a better opportunity for you to sit there and say, you know what, I'm glad you asked about that, because truthfully, you know what, you'll sleep better at night. You'll be alone with your cats, but more importantly, it's not going to help you with any eye strain. I have something that's going to be a difference for you. Now, I know we're talking about dry eye update. And to be honest with you, it circles the globe around the sphere of our eye that everything we do is qualitative tear production. And to me, one of the things that is so prevalent in what we've been doing for the last 70, 100, whatever, 200 years is telling our patients, you need to put in more drops. To me, I've always assigned an artificial tear as nothing more than palliative, something to do. And I always tell my patients, these are like a mint. If you think of an artificial tear, and there are great tears, you know what? We have ones that are, digital or hydration, or we have ones that are blink, super cute, right? We've got fresh coat, right? We have all these great names and different products, but the reality is they're like a breath mint. Okay. Those of you at home who are probably eating some garlic, or maybe they're like, yeah, your breath, it's not doing good right now. So you put a mint in, and about 15 minutes later, somebody says, did you have curry? And it's like, when? It's like, I don't know, but I'm smelling curry. You get a little sense of that. To me, what I always love to do is sit behind a slit lamp and do exactly what Melissa just said. There's an acronym that came out of the ASCRS, and that was basically LLPP. And basically what Melissa said is you look. First thing you do is you look at the patient. You're looking for all the things that she described. You're looking for lag ophthalmos. You're looking to see their blink rate. You're looking to see if there's maybe some trichiasis. You're looking to see if there's any signs of any, carcinomas in and around there. The second thing you want to do is lift and pull. And literally what you do is you take the upper lid, you lift it, and you pull it back. To look for those collarettes we just talked about, okay? To look to see if there's any like concretions or Meibomian gland, capped glands that are underneath there. And the last P is push, okay? Like salt and pepper, push it real good. Is pushing on those Meibomian glands to look for some of that juicy love. And this is my favorite part of the exam. No, seriously, you push on that. And those pictures that Melissa showed, I mean, we all live for those days. We're like, hold it. Yeah, look at that. That is, ugh. I will literally tell a patient as I'm sitting behind the slit lamp, because I want them to know, I want them to be engaged in the fact that what they don't perceive they have, I am telling them they have it. Melissa made an awesome point about the difference between signs and symptoms. If you ever want to look at the disease state that is so dysfunctional, it's this one. Because again, when you say, well, your eyes are dry, they go, yeah, not so much. No, I'm pretty much telling you, don't think they are, but thanks for sharing, right? I'm going to write you a prescription, not going to use it, right? I mean, to me, I'd rather walk in and basically say, look, I'm pushing on you. Whoa, I'm seeing something here that's concerning me. And they're like, what is it? And I'm like, well, I vomited in my mouth a little bit. So hold on, okay? And then I will look there and say, look, the glands along your lids are getting basically obstructed. They're also getting inflamed. So we need to talk about what we can do about that. While I'm back there, I'll say, I noticed that you put an artificial tear in. Do you feel you need it? Well, I don't know. I just, sometimes I'll put it in. I go, yeah, sometimes I just drink Pepto-Bismol for no reason. I mean, you're doing it for a reason. And I sometimes will remind patients at that moment that they're nothing more than a mint. Put them in to freshen up your vision. If you're a doctor who's telling a patient, do a drop once a day, what do you want them to do? 6 in the morning and then forget it the rest of the day? If you say 4 times a day, what if they do it at 8, 9, 10, and 11? I'm done with my drops. To me, this should be like a therapy when they think they need it to freshen things up. And sometimes I will look at a patient behind the slit lamp and I'll say, and you could probably use a mint right now. And I leave it vague. With the masks on, it's not quite, but without masks on, I'm somewhere in between there. And every single time I say that, I'm always reminded of a patient that I saw about 15 years ago. And sadly, this is my life. I looked at him and he said, dude, you love coffee. And I go, excuse me? He goes, yeah, your breath reeks like coffee. And I go, wow, you love dogs, right? Yeah, you can think about that one for a second, okay? Yeah, he didn't come back. And then to be honest with you, I don't care. Bye-bye. So when you start thinking about, what we're doing to help our patients, we have to think outside the box. But the bigger thing that I really want to impart is to basically tell and talk to you about providing your patients with opportunities to make a difference. Now, some of the things that I'm going to share with you is that Melissa touched on them, and I can't do them justice because she had some really good graphics, and she's a much better speaker than I am. So, but I will touch on them a little bit. So to me, if you've established for your patient that you see a problem, and more importantly, you want to be proactive and preventative. If your whole modus operandi as an eye doctor is for your patients to never come back complaining, think about this one for a second. Is that we ask our patients to complain. What's your chief complaint? And I'll be honest with you, I get tired of hearing people complain. I mean, honestly, they start talking and I'm just like, wow, what's for lunch? It's like, oh, I'm sorry, did you say something? Yeah, I'm in that, okay? More importantly, it's like, wouldn't it be great if it was like chief compliment? They come in and they just say, first and foremost, your outfit is amazing. And I'm like, these scrubs, come on, stop it. I mean, so if our goal is to make our patients, and again, I'll draw back to glaucoma. Do you hope your patients, when you're treating them for glaucoma, come in with pressures of like 40 or 50? So you can say, yeah, that's why you came in, because I'm going to help you. No, you want their pressure to be stable, the same. You want to be able to get your 99212 or 99213, maybe build an OCT and just keep doing you. You do you, boo. Bye, right? And then just hope you don't get a call from the pharmacy saying that they're not going to, provide you with their medication anymore. To me, if we establish the fact that our patients understand that this is going to affect the quality of their tears and everything they do afterwards, the quality of their vision is going to suffer, then I'm again going to say to you, why do you not do things the minute your patient's sitting in the chair, regardless of why they're there? You have new tools in your armamentarium. When we start thinking about the prevalence of this disease, it's estimated that 16 million patients have been diagnosed with DEAD. Okay. And that's dry eye disease for the people that are playing at home. 16 million have been diagnosed. But here's the sad part, peeps, is that they estimate that somewhere around 38 million Americans have this disease. Now, where do those numbers come from? I'll tell you where they come from. In the 1970s, they did a study called the Beaver Dam Study. And what they did is an epidemiological study of everybody that lived in Beaver Dam, Wisconsin. And you may see the Beaver Dam floater study. You may see the Beaver Dam diabetes study. You may see the Beaver Dam proctology study. They went and did everything to these people. And so in 1970s, they found the prevalence of this disease state was about 14.5%. Well, now fast forward. We are now in 2005 to 2008. They said, you know what? They had kids. So why don't we do the Beaver Dam Progeny study? And they did. And between 2005 and 2008, they did a progeny study. And guess what they found for the prevalence of the dry eye? And unlike Melissa, I'm in a virtual world. I will ask rhetorical questions and I don't expect answers. And so you don't have to answer me. I will share with you. It was 14.5%. The prevalence of this disease state had not changed in 35 years. But here's the caveat to that, my friends. And yes, we're friends. I literally had a patient once say to me, I said, my friend, and she goes, we're not friends. And she threw me, to which point I'm like, stop it. You're crazy. What time are we going out tonight? I made her feel so uncomfortable every time she came in. I'm like, so what are you doing this week? She goes, can we just get this done? I go, mm-hmm. People always say to me, what's your HR file like? I mean, it's a file cabinet, okay? It's a cabinet. It's still a work in progress. Is that literally, if they went back and looked at 2005, 2008, they found that nothing changed, but oh yeah, things have changed because the average age of the adults was in the 40s. The average age of the kids was in the 20s. What you're doing is we are shifting this disease state younger and younger. And everything that we know we do to our eyes and our kids are doing to their eyes changes it. Now, the other thing that I will share with you is what happened in 2006 that changed everything. That damn Steve Jobs, that iPhone. Yep. Because honestly, right when I say iPhone, I know a couple of you are like twitching. It's like, I mean, I don't know if they posted my new TikTok dance, but I hope. I mean, how many likes did I get on it? I'm old, but I'm not old enough that I'm on the Facebook. So, I mean, I don't have any social preference, but our patients do. But it's sad if you think about it, only 16 million people have been diagnosed, and yet there's approximately 38 million. But I got to be honest with you, I think that number is ridiculously higher. And I think part of the problem, and I know that I'm probably an apostate by saying this, as an optometrist is that I think part of the problem is we make it too hard for us as clinicians to diagnose this. We come up with these definitions of multifactorial diseases, loss of homeostasis, accompanied by ocular symptoms, hyperosmolarity, ocular surface inflammation. Here's the bottom line, people. Your patients have tears. Their tears suck. We have to do something to make it better so they can keep doing what they want to do. Stay in their contacts, look at their kids, be on their computer. No, they don't want to look at their kids. I don't know. This guy's like, no, I do not want to look at my kids. I have a feeling Father's Day came by and you were scared, right? Waiting to see if you got a text. And it's like, whew, missed that one, right? I randomly on Father's Day will send messages to people that I know are single. And I say, Happy Father's Day. And it's like, do you know something I don't know? I go, you'll find out. So yeah. I mean, this is a vicious cycle. And honestly, I always think of Susan Powder back in like the 1990s or 2000s. She was that spiky blonde haired girl that we got to stop the insanity. And some of you guys are way too young to even know that. And older people probably don't even know what I'm talking about. But that's our job, is to stop this insanity of this inflammation. And this cycle of inflammation is constantly integrated by lots of different things. And we can't stop our patients from doing them. Right? We can't stop them from going outside, being on a computer. We can't stop them from taking systemic medications. There's probable risk factors that we can maybe change, but there's also hereditary and other components we can't. So try to stop doing that. Instead, saying, look, I'm going to help you be you, right? And it goes back to that whole bad boy thing. You just got to deal with it, or that bad girl. Why is it there's never bad girls? Why is it always bad boys? Because there are a lot of bad girls out there. To me, when we start looking at younger and younger patients, the question is, then what can we do to help them? So here is a relatively new product that just came to the market, which is called Suvius. See, I got the microphone on, so I'm acting like Genesis, okay? I could be like Phil Collins on the drums, okay? Thank you. Thank you. I'm here all week, people, okay? I'm going to be, I'm opening over at Cosmo. I'll be on the corner right by Elmo and whoever else is over there. But Eysuvius is the first and only medication indicated for short-term relief of dry eye. Now, why is this relevant? It's relevant because when you prescribe a medication to a patient, you want them to understand that you see them. Now, I just said to you that it's indicated for dry eye, and I don't tell my patients they have dry eye. I make it all about the tear film. And so in this particular instance, what I would do with the patient is I would look and I'd say, you know what? I noticed that your eyes look a little bit more red. I also noticed that you're using the Lumify, like it's going out of style, okay? And I get it, but your eyes are still red. And where is the redness coming from? Inflammation. That quality of your tears is suffering. There is a brand new drop that just got approved. It is a corticosteroid. The opportunity for you is to be able to quell that inflammation so you can keep doing the things you want to do. Now, I'm going to challenge you guys. And I'm challenging because, I hit the microphone, sorry. I'm going to challenge you because I believe that is it okay? Yeah. I believe that we see and have seen episodic dry eye for a long, long time. And what do I mean by that? I know I could hit it against my chin. Is that for the people at home, they're like, what's that crackling sound? It's the microphone hitting my scruffy David Cross beard here. Is that we've been dealing with this for decades, but we've been treating these patients differently. And how have we been treating them? We've been treating them thinking or making the assumption that it's allergic conjunctivitis or it's a blepharitis. How many of you, without raising your hand, just think it in your head, have written a prescription for Tobradex ST or Xylet? And when the patient's like, oh, thank you so much, my eyes feel fantastic. And then about 6 months later, they call back and they say, yo, I just need another refill, man. It was so good. It felt so good. And you're like, and then remember what I told you before about not wanting to hear patients complain? You're like, yeah, refill, give them 3. Seriously? Yeah. Because the aminoglycoside is our way of kind of assuaging our, worry that it's a bacterial infection, even though we know that bacterial infections are what? They're self-limiting. Within about 5 to 10 days, they go away, but nobody wants to wait that long. That's like having myokemia and telling some patient, oh, your lid's going to twitch until it stops twitching. Thanks. I'm going to go see a real doctor now. Okay. But what is the workhorse that's helping your patients feel better? The dexamethasone. But dexamethasone is a hell of strong. Has anybody here written a prescription for dexamethasone? No, you'd be like, damn girl, why am I doing that? I can give them Durezol, but are you going to put Durezol on a patient who has ocular surface inflammation? The answer is yet, unless it's covered by their insurance. And then you're like, go ahead, because I just don't want to have to see that patient. We've been seeing these episodic flares. Think about your patient who is binging something and comes in, my eyes just feel irritated. Your contact lens patients who come in and say, I feel like my contacts don't feel as comfortable. For the last few weeks, I've been having problems. If you live here in the Southwest, it's like when the weather changes, when it gets to be in the 70s or 80s, our patients start having problems. When it's 115, nobody has any problems because everything is so dry. And more importantly, nobody's going outside. We're just lounging in our pools and going, well, isn't it crazy how it's like we're kind of cold, but we're hot at the same time? You guys know what I'm talking about, okay? Unless your pool is like bath water and then you get in and go, yeah, this nasty, okay? So if we think about these episodic dry eyes that our patients are experiencing, much like iritis, or much like patients who have Sjogren's, or much like patients who have lupus, is that we can sit there and give our patients an opportunity to make a difference. We have to start sooner because there's a difference between the innate immunity and the adaptive immunity, which basically means these chronic dry eye patients that we have started at this very early stage. I always look at kids and I think of it the same way. For those of you that have kids, my two friends over here, okay? You see those kids when they're in their teens and they're like, screw you, mom, I hate you. And the mom's like, oh, he's just being special today. No, okay, that's adaptive. We should have hit that early. We should have like hit it and quit it early. I just made that up. I'm not sure what that means, but it sounded good, okay? My wife looked at me when I said that the other day. She goes, it's not what you think it is. And I'm like, okay. Is that when they're little, you can make a difference and go, that's not how we talk to mommy and daddy, okay? That's, you know what, right? And so to me, much like inflammation, if you hit it early, if you stop it and quell it early, then those exacerbations are going to be less. And that's the difference between innate and adaptive. We have all these examples that our patients are going through. And again, I am not the guy to sit there and say, you know what, you want to wear those colored contacts you bought from the swap meet, you go ahead. Okay, I can't stop you. But if you're going to, then I'm going to give you something so you can stay in them more comfortably. You know, like when we think about like restoring homeostasis, that drop that restores homeostasis, or cyclosporin or lifitegrast. But for those exacerbations, those periods your patients have problems, and we need to be able to get in there. And you might be sitting here saying to me, Mark, my patients don't have this. And I'm sitting there saying to you, yes, they do. Do you guys all get those surveys sent to you? Like M-Panel or Opinion Site. It's like for, 50 minutes of your time, a contact lens survey for $100. And you're like, oh yeah, I'm all over this. And then you get deep into that where it's like, what percentage of the contact percentage patients of that patient? You're like, why did I even do this? But you've started it and it's like, they've got that carrot. You see that hundy way at the end there, right? And then your internet goes out and you just basically say, what did I just do this for? Until the next one comes. Well, our patients are the same way. They get studies. So these dead patients did this survey and they asked them point blank, do you experience dry eye flares? Do you ever feel like your eyes get worse sometimes more than others? 80% said yes. They then said, do you only experience these flares? 45% said yes. And what's funny is that we don't think our patients are experiencing this because we're not asking them. And honestly, I don't ask, I tell them. I will look at a patient and say, you're going to have this, so I'm going to give you an opportunity to quell that inflammation. Now, what's unique about Eysuvis is that this is Kala, okay? Any Real Housewives of New York fans here? Yeah, if you know what I'm saying, Kala. No, nobody? I mean, I'm not either. It's on the TV, and sometimes I'm like, what is that? Ramona and stuff. No, is that Kala Pharmaceuticals basically has taken what we know to be true, which is we need to get the drug into the eye. So they are using a nanoparticle and they're making the lotipratinol like super, super tiny, but then they're coating it in mucus. And so they're down with some MPP. Okay. I'm keeping the theme going here, people, right? ODP, I'm down with some MPP. You know me. Okay. MPP, nobody? Okay, good. Keep it that way. Okay. Is that it coats it in this mucus so that when it gets to the mucous membrane, it basically says, yo, you know me, I'm coming in, right? You can't stop me. Okay, I'm too legit to quit. I'm going to make it all the way to the epithelium and drop off that lotipratinol. And literally what you see here is a unique opportunity to bring low-dose pradinol etabinate 0.25%, which is an extremely low concentration to the epithelium, okay? And in fact, what makes that also very unique is the notion that it's 100 times more concentrated in the cornea than it is the anterior chamber. And I know what you're all thinking. You're like, Mark, it's a steroid. Okay, I'm gonna write a prescription. I'm gonna send it to the pharmacist. The pharmacist is gonna say, oh, well, we can put you on a generic. But here's the deal with that, is that first and foremost is the generics don't all act the same. When you're concentrating a low concentration and getting to the tissue you want to, low-dose pradinol etabinate breaks down. It's an ester-based steroid. More importantly, if it's only hitting the anterior chamber, we're not seeing high pressure spikes. Specifically in Isuvis, they had 3 patients that were greater than 21 millis of mercury and greater than 10 total. That accounts to 0.2% of all the patients in their clinical study. When I tell a patient that they're having episodic flares or dry eye, what I do is I basically say, look, there's a brand new drop that was approved just for this. And I also tell them it's a BAB. And literally, so I'm going to send you on your way with a coupon. I'll let, Kala talk to you about how that works, but it's literally can be as cheap as $25 and it can be as expensive as $60. Most generic steroids, people, cost about $50 or $60 anyway. And so what's nice is that you sit there and tell a patient, look, I'm giving you therapy on demand. It's a BAB. And they're just at some point, somebody says, what's a BAB? I'm like, dude, it's a big ass bottle. Okay. You get like 10 milliliters of this. So it's therapy on demand. Now there's another drop out there, which has been approved. And this is kind of going old school, but it's also moving forward. And this is Flarex. This is your FML that we're all kind of like comfortable and happy with. This is fluorometholone acetate. And literally what you see here is that it's a topical steroid for the treatment, and it's indicated for ocular surface inflammation. So I've got 2 drops that I just told you that are both indicated for the disease state that you're worried about. One of them is Flarex, and this is from Eyevance. And what Flarex basically has the efficacy of Pred Forte with the safety of FML. Now, if you've ever tried to use fluorometholone for an anterior surface, it's literally, you might as well just put them on an artificial tear because it really doesn't do anything. But the acetate portion basically works much better because it penetrates through that ocular surface that we need to get it to. We see here that it is a steroid. It's an ester topical ophthalmic suspension containing 0.1 fluorometholone. It's formulated at physiological pH of 7.3, and basically it's indicated for the treatment of steroid responsive inflammatory conditions of both the palpebral and bulbar conjunctiva, cornea, and anterior segment. I know that when you say steroids and you're like, really, dude, steroids for an eye infant? Think of all the steroids you've already been prescribing. Why would you not prescribe something that is indicated for what you're talking about? And I get it. We all worry about malpractice. And it's like, what is malpractice? Malpractice is basically going outside the lines of what standard of care is. What would a group of your peers do? And a group of your peers would say, well, why didn't you start them on a drop that's indicated for what you're actually treating them for? To me, I get my patient a whiffeth. It's what's in it for them. I don't even know if that's right. I make it up. I'm like, I'm giving you a whiffeth. And they're like, a BAB, a whiff this, what the hell, who are you? And I'm like, you know me, okay? I'm down with MPP. I mean, so to me, if you're gonna see a patient, you're gonna talk inflammation, then you've got to concentrate on helping your patients. And an underlying theme here is there's, I believe, an exhibit hall, right? Or a virtual exhibit hall, or better yet, you all have reps. And I love talking to reps because it's just, they're so incestuous. Do you ever notice that they all just move from one company to the next, right? Oh, I heard Kala's hiring. Kala. So there's one rep who works for B&L in my town, and my Kala rep left. And so every time I see him, I go, Kala. He goes, why do you keep doing that? Just saying. Just saying. He goes, yeah, I am thinking about it. I'm like, Kala. He goes, no, stop it. Is that what's nice about it is they always say the same thing to me, is that our profession is one of the few professions that gives the reps the time of day. We listen to them. And honestly, I feel that it's quid pro quo. Okay. I literally feel like they're giving me something to give to my patients. And what they're giving me is a little bit of education or opportunity for them to be able to treat their eyes and manage it. And so I love hearing about their rebate programs. Ivance for Flarex, they have a rebate card that's $45 or less. For what I already told you about Kala with theirs, right? It's like 25 to 60 bucks. To me, telling a patient, look, this is what it's going to do for you, and I'm going to help you and hook you up, makes you a partner in establishing that you're going to maintain the quality of their tears. Now, some of you might be seeing on TV that there's something called TED, right? And we want to make sure that our TED patients don't get dead. Okay. And truthfully, if they are dead, that's one less patient I have to see. And I know you're looking at me like you don't believe me. Oh, I'm serious. I'm the most misanthropic doctor you'll ever meet. When they come to me and say there's a patient ready, I say, why? Right? True story, 100%. Every time I walk into a lane and a patient looks at me with this disingenuous, hi, how are you? I literally just tell them I have diarrhea. And I wait to see their response, and then I just move on with the exam. TED is thyroid eye disease. And if anybody here watches Bravo, Top Chef, right? Solid. Any Top Chef? Nobody in here is watching Top Chef? Somebody virtually is going, those people are monsters. I'm like, yeah, okay. Well, the finale is on Thursday, so we might as well just wait. But if you watch Bravo or AMC or whatever, you'll see TED commercials. And TED, and it's funny too, because the commercial they have is this woman wearing these super dark sunglasses. Like she has like some sort of like mesophobia or something. And I just made that up. But I mean, it's like, I've got TED and I'm like, I don't know, not a lot of my patients come in with like super dark glasses acting like, you know, they can't see. TED is thyroid eye disease, and there is now a treatment for that. This is not a treatment you're going to be doing in your practices, but I think it's important for you to know what it is, because literally, if you see a patient who has thyroid disease, they may say to you, I saw this commercial, so you can be able to explain to them. Okay, and this is Tepeza. Tepeza is the first and only FDA-approved thyroid eye disease. 80% of Graves patients have ocular involvement, but only 15% of them develop severe impairment. So basically what it means is that most of these are going to have dry eye type symptoms. And when we look here at the difference between thyroid eye disease and Graves' disease, basically the muscle and fat tissue behind the eye becomes inflamed, red, or swollen, and that's in TED. In Graves' disease, the thyroid becomes overactive, giving them hyperthyroidism. So it's literally patients that have Graves', which is the thyroid, can develop symptoms or problematic, which we call thyroid eye disease. Gritty eyes, sensitive, redness. Does this sound familiar? Right? It sounds like every single patient who comes in, basically, if you kind of like tease it out a little bit. Here's a good example, you know, of that foreign body, that exophthalmos, right? This is somebody who you just told them that their insurance isn't going to cover that Procare you put them on. Yeah, look at that. Okay. What? Okay. $1,400. And I'm like, yeah, we probably should have told you that before we did the Procare bilaterally, but that's a separate story. Classical symptoms, eyelid retraction or the Dalrymple sign, or even von Graf sign, that eyelid lag, when you have them blink. Remember, look, that whole thing about look, watch them blink and you see their lid just kind of lagging and sitting up there. So what does Tepeza do? Tepeza is, it blocks the receptors that treat thyroid eye disease at its source. It blocks the receptors, reducing the muscle fat, and more importantly, the tissue swelling that your patients see. This is an infusion. So this is almost kind of like your patients who have dialysis. They have to go in and get this infused. And it's basically every 3 weeks for a total of 8 infusions. It lasts for about 5 months. Their first infusion takes a couple hours, and then it's about 60 to 90 minutes. So is this something you're going to do in your practice? The answer is niet. But is it something you should be able to talk to your patients about? Yes. We also now are talking about something that is that my time's up? Thank you, everybody. Okay, unlike Melissa, I am not mindful of time. And if that's a text message for me, tell them I'm a little busy. This is keratin neuralgia. This is another thing that, you know, I almost kind of feel like we keep getting inundated with, here we go again with the add-ons. Now I got to do a speed test. And now I got to ask my patients, do you like the apposition of your lids? Do you think you look like old? Are you sleepy all the time, right? Now, something else we have to think about is, are our patients neurotrophic? Is there a sensation or a loss of sensation along their cornea? And if you think about it, a lot of patients, and I always think of contact lens patients where they've worn RGPs or sclerals or hybrids or duets. And I'm just naming contacts because I don't really know contacts very well. I'm just going to keep going, right? Ciba Visitint, 8.6 in a little bottle, right? U4 out the door. What? Is that those patients start to get a little neuralgia. They don't feel anymore. Those patients that you start on cyclosporin and then they go, my eyes are burning a lot more than they ever have because they have some neuralgia. And we now have a treatment for that, okay? When we start seeing innervation as the key treatment here, sometimes they might have intense pain, like a trigeminal neuralgia. These patients have SPK that might lead toward a corneal ulceration. And the treatment has been traditionally conventional dry eye, steroids. We've all been using maybe a little bit more autologous serum, as well as that amniotic membrane that I just described. Okay, this is a classic patient of mine. Okay, this is a patient who's coming in for cataract surgery, and literally what he decides to do the night or it's a couple of days before he's taking his drops, he basically hits the tip of the drop to his eye. Now, I'll be 100% sincere with you. I oftentimes will tease whenever I read a package insert where it gets to the part where it says, do not hit the tip to your eye. And then I start thinking, but think of how much money we can make if every patient did that. I mean, seriously, that's like a couple of 99213 visits. We can do an amniotic membrane, right? It's like, yeah, okay. That Tesla you saw driving down Las Vegas Boulevard, 2 of those. But this guy right here, okay, he hit his eye with the tip. His vision's 2200. Okay, this is what his eye looks like now. So I'm like, I got you. Conventional treatment, right? What are we gonna do? We're gonna drop a bandage contact lens on him, and then we're gonna like go, woo, it's gonna heal itself. We'll see you back tomorrow. The truth of the matter is I don't subscribe to that. I mean, when we think about recurrent erosions and other issues, I think we have to, again, stop what we're doing and change our style, because this is a active treatment versus passive treatment. But I did that. Put him on a bandage lens, put him on an antibiotic. I said, I'll see you back in a week. He came back and he basically said, hey, I'm going hunting next week. I mean, the nicest guy, but the contact was gone. He had no idea. And his eye was about 99% worse. And I just sat back in the slump and I went, and his wife's like, are you okay, honey? And I go, no, no, I'm not. I did a cotton tip sensation. So I don't have a corneal sensitizer. I don't even know what they're called. I basically just take a cotton tip applicator. I pull one little wisp out and I'm like, you feel that? And he goes, yeah. I go, do you feel that? He goes, feel what? I go, boom. That's what I thought. You could check all 4 quadrants. I usually just like to come at it temporally and hit the center. And when we're seeing dry eye patients, or we're seeing patients that have significant SPK and they're like, I'm good, right? Like Melissa talking about Demodex, right? And you see the Colorads and like, I'm fine. I'm like, no, you're not, because those are nasty. Okay, you need to do something about that. So I inserted Procure Slim, but I also started him on Oxervate. Oxervate is your first and only approved medication. This is a biologic, which basically stimulates neural growth factor. The neural growth factor plays a role in the function of helping the nerves generate and, more importantly, basically function. Now, we see that when we start looking here, this endogenous nerve factor is a high affinity nerve growth factor in the anterior segment. Your patients basically have this naturally occurring neurotrophins, and the neurotrophins basically are stimulated by this new medication. This is a not dwarf drug. This is a, God, I forgot the name of the drug. It doesn't matter. It's basically, this is a drug that's only been approved on a limited basis because there's so few patients that have this. Orphan drug, nailed it, orphan drug. It's an orphan drug. So it's hell expensive, people. And do not be caught up in the fact like that's gonna be like 40 grand. No, it's not. Most Medicare patients can get this at a natural copay. And more importantly, Dompay Pharmaceuticals is gonna help you get there. They get 7 vial adapters, 42 pipettes. It's 1 dose recording card. It gets mailed to your patient's house. I started my friend on some Oxervate. This was the first patient I ever did this on. I've had about 8 patients over the last year and a half that I've used Oxervate on. This stuff works. I mean, most, like 70% of the patients, 80% in the clinical trials had almost complete resolution by using this. Okay, 80% remained healed for more than a year. This is Oxervate from Dompay. Okay, What about some investigative drugs, ones that you don't have? And Melissa touched on these, so I'm not going to get too deep into this, but I am hella excited about some of the new drops. Tarsus Pharmaceuticals has assembled a phenomenal team. I'm not just saying that because one of them is like looking at me right now. What's up? But it's an awesome opportunity for us to actually treat a condition that we see in our patients. And so Melissa had mentioned this before when we started thinking about Demodex. I mean, how many of you guys have actually looked at a patient? You've looked at their lids and just said, how are you doing? The patient's like, I'm good. I'm just here for my routine eye exam. And you're like, how can you be good? I've used this picture forever talking about cataract surgery. And my question to every surgeon or patient or doctor who sends in a patient to my practice for cataract surgery, I'm like, did you even look at the lids? Like, yeah, but the patient's not having problems. I mean, is that how we want to manage our patients? Is that we want to wait till they have problems, or we want to do something before it becomes a problem? Especially when you think of refractive surgery or contacts, as Melissa said. So start with contacts. I'm going to help you stay in your contacts more comfortably, and then move on to refractive surgery. And cataract surgery is the new LASIK. Like white is the new tan. I'm telling you, cataracts is the new LASIK. Why? Because it's ridiculous. I can see all three distances. My vision's never going to change. Insurance might even pay for it a little bit. Oh, hell, sign me up. It reminds me of the old tampon commercials, right? You can go horseback riding and swimming. And I'm like, I want to go to Tampex. How do I get there? All right, let's do this. And it's like, oh, I can't? I'm like, whatever, rip off. When you see this, it should be see it, true. I mean, I cannot stand, and I mean, I can't wrap my arms around anymore. This is not Ben Gaddy's eyes, but this is from Ben's practice. And Ben is just so basically ensconced in this notion that he feels Demodex is the root cause, because he's from Kentucky. It's almost like root. He's scared. He's scared of this thing. Is that he thinks that this is basically a larger part of the problem of what we see continues this vicious cycle. And when we start thinking about these collarettes, if you do that look, lift and pull, LLP, then you're going to see these. You can't just take it by granted that you're basically looking at these patients and thinking the collarettes aren't there or they don't have the Demodex. Yeah, I mean, come on. It's just, we can just keep going. Okay, whee, right? This should be the new hang in there poster, shouldn't it? Right? Hang in there, little buddy. Hang in there. I mean, and I'm not advocating you go out of your way to say, by the way, you've got some nasty little mites in your eyes, okay? But I will say is that, look, it's symbiotic. We have lots of different organisms living in our body. As we get a little bit older, they sometimes proliferate. I know you're only 20, but they're proliferating, okay? They're enjoying what you're feeding them, and they're basically, it's like Pompeii, right? They're blowing up. When we look at rosacea and Demodex, there's been enough studies to show that there's a correlation here. And I mentioned before, Melissa had much prettier slides, but this is the same data. Okay, I actually was involved in this study. And literally what Tarsus did is they basically commissioned about, I think was it 200 of us, 1,121 consecutive patients in 8 clinics, okay, MDs and ODs. And this is literally what I did. I walked in, I sat behind the slit lamp and I said, hey, how are you doing? And I looked to see if they had collarettes. In my practice, it was close to like 68% of my patients that I walked into. This was IOP checks. This was contact lens checks. They weren't my patients though. It was status post LASIK 1 week. It didn't matter what it was. I walked in, I looked, and it was almost 70%. And I remember Maza, who works at Tarsus, I talked to her, I sent her a message and I said, this is ridiculous. I go, I've never realized how prevalent this is. And I've also ashamed of myself that I haven't thought about how I can be helping these patients to get away from this. So this novel therapeutic treatment, which hopefully we'll see, maybe, I'm going hopeful, maybe the end of the year, maybe next year sometime, we should start talking to our patients about managing and cleaning this, and then also saying, look, we're going to have a way that we can eradicate these. This is a phase 2 study that they did. Look at the death. This is dead. They're dead. They're gone. Their phase 3 study, which they are just finished, and now they're going on their second phase 3, is ridiculous. I mean, it literally within 6 weeks, you've found almost 0 to no collarettes, and collarettes are pathognomonic for this condition. And there's some of those pictures. And one of the things that I think Melissa touched on too is that you see less redness, you see less hyperemia. patients actually see or feel a little bit better. Now, there's another drop that Melissa didn't touch on. And when we start talking about Meibomian gland atrophy, and I'm not going to get into the whole discussion about how we got there, but it's currently thought to be the leading cause of dry eye. And I wholeheartedly believe it. To me, this is low-hanging fruit, people, when you want to get patients to basically buy into what you're selling them, which is the quality of their tears is nonsense. We need to do something different. And to me, starting on the Meibomian glands, the lids, which is 86% of all patients have dry eye because of this. Here's some prevalence studies, and I'm just going through them real quickly. This was LEMP. But one of the things that I think you have to wrap your arms around is that these are hairless follicles. And since there's no hair there, but they act like a follicle, then they build keratin. And keratin is what makes our hair and our nails. It makes shells. It makes things strong. And these are all disulfide bonds. Melissa showed you a picture of tear care system, using the expression and getting all that nonsense out. But one of the things that happens is that keratin builds up on top of there. So what you can do to help your patients is to remove the keratin. Now you can go in, you can debride, and I don't care who you are. I do these nonsense videos for, it's called Collaborative Corner for BMC. And I specifically was doing one and I'm like debriding, and my wife's like, why are you saying debriding? I go, it's D-E-B-R-I-D-E. How do you say it? She goes, debride. And I'm like, really? What are you, a speech and language pathologist? To which point she goes, yes, I am. And I'm like, I don't care. So I was talking with Doug DeVries and I'm like, so we're going to debride. He goes, what's a debride? And I'm like, who? It should be debride. I'm changing it. Just like I think aesthetics should be aesthetics. When Selena's here, ask her about that, okay? Because I think aesthetics, we're thinking about the wrong part of the body, okay? And so if you think about keratinization and removing the keratin, there is going to be a product that is coming out of Australia, eh? Okay, some of this Australian accent, right? And this is AZRMD001. This is from a company called Azura Pharmaceuticals. And Azura basically has figured out a way to chemically denature these disulfide bonds. If you were to try to heat them up, it would be about 1500 degrees Celsius. Okay. More importantly, if you can denature them chemically, we can break these bonds. So this drug is going to be a kerastatic, a keralytic, and a lipogenesis. Is this going to take away doing thermal pulsation? No, but maybe what it's going to do is open up the gland so thermal pulsation works better and longer. Or maybe it is going to be a treatment at the end of the day. They've shown some phenomenal studies. They're phase 2 studies. They're starting a phase 3 study. So we're going to see this very soon. I'm going to almost end on this. And if I can seal 2 more minutes, can I? Thanks. Oh my God, you're amazing. Okay, so hey, this is ACA1. And I say that just to be funny because I met with Al Cabot yesterday. I was in Denver at the American Optometric Association. It was sad. It was really sad. But Al pulled me aside and he said, oh, you guys have to make, okay, so Selena, when Selena's here, just say, excuse me, can you tell us about ACA1? Okay, because Selena was giving a talk and she goes ACA1 and Al goes ACA1. What is ACA1? It's OC01. But I think ACA1 sounds better. I'm just going to say that. Okay, this is Oyster Point. Oyster Point has already gotten their letter of approval. They're hoping to basically have this FDA approved by October of 2021. This is a drug that is going to be in your hand, or better yet, up your patient's nose, because this works on the same premise that TruTear did. In fact, the father of TruTear, Michael Ackerman, is the person who actually created this chemical way of stimulating the trigeminal nerve to basically get into that like Hutchinson's, right? But we're reversing it the other way around. And literally what this is going to do is stimulate the ability to make basal tears. 34% of our basal tear production is by inhaling something. And this is a product that basically works by putting that into the tears. And so it's creating their own tears. So their onset study, their designs, and I'm going to skip through this for lack of time, but their phase 3 study design, basically, it was a no placebo running it in. They basically showed Schirmer scores, and all of this is in your notes, right? Do they get notes? Yeah, it's all in your notes. So you can read that. Okay, you don't need me to sit here and read you the slides. Bottom line is the efficacy of the data. Here's their onset data. We can see that they improved symptoms. Okay, and this was in a desiccation chamber. They also improved their symptoms statistically significantly in all their studies. I have way too much data on this, but it's exciting because it's going to be approved. It's going to be approved literally probably before the end of the year. Last thing that I want to end on, because I know that Abby V is here. Bottom line is we talk about our eyes, our patients' eyes. We talk about how important it is and how great it looks. Our patients also don't want to wear reading glasses. There will be a presbyopic treatment for our patients, a pharmacological treatment to get them out of context. This will be probably before the end of the year, Presbysol. And why I bring that up in a dry eye update is because when you're looking at your patient's eyes and you're talking to them about new and exciting opportunities, and you're putting a drop in the eye, that drop has the potential to change the inflammation. And more importantly, if you're not treating the inflammation you're seeing, you're not helping them. You guys have been amazing because you really didn't ask any questions or raise your hands. I appreciate that. And enjoy the rest of your day. And I think mimosas are going to be hitting, we're going to be tapping some mimosas soon.
Yes.
And thanks, everybody.